Hello, everyone. I really appreciate you staying around this afternoon. I hope I can hold your attention and make your time worth it. So I'm here to speak to you about a bit of work we've done in the health economics unit, helping ICSs to understand patient preference for people with COPD. This is a piece of work we did across 5 integrated care systems to help inform resource allocation decisions this year. That's what I'm talking about. Why I'm talking about it is I'm hoping to persuade you all that there are ways that we can quantify patient preference, what people want, in a way that is useful for proactive decision making. I'm sure you're all aware, patient public engagement tends to be done either by getting a token patient in your board meeting and saying, look, we've got a patient there, therefore we engage with patients, or you do a big, large set piece engagement exercise where you find out useful things like people don't want to wait long for their treatments, or people really like the NHS. It's helpful, but sometimes we need to be a bit more specific. So in this piece of work, we use something called a discrete choice experiment. So this is a kind of analysis where what you do is you ask people a series of different options. You get them to choose between those options, and that helps that you then apply some Bayesian statistics to it, and then you can understand what is driving people's preference. So here's an example of what one might look like if you're speaking about perhaps what food to sell in a restaurant. So you've got your attributes. These tell you perhaps things that are important for people when they're deciding to eat. Might be how tasty the food is, how many calories it will give them, what the environmental impact is. These things in here are then called levels. So you vary these based on predetermined lists. Get people to choose between them. You vary them like this, and then apply some Bayesian statistics to it to understand what's driving preference. So you can tell not only what attributes were most important for people's decisions. Did they prefer food that was tastier, or were they more worried about their environmental impact? You can also tell which of the levels within this are more important. Did it matter if something was disgusting or edible, or actually was that not important for people? So we did that for COPD. This was sort of the outline of what our survey looked like. So we had 6 attributes. These were informed by a systematic literature review and a technical reference group. So we've got treatment outcomes, the way people like to receive their treatment. So online individual, online group, in-person individual, in-person group. Average travel time for treatment, how much people would spend on treatment. So, treatment would be free, but perhaps there'd be travel costs, that kind of thing. How long people would wait for treatment, and the type of staff delivering treatment. Who did we ask? So, as I say, we did this piece of work with 5 ICSs. They helped us distribute this survey to patients. So we didn't pay anyone or do much work ourselves to distribute this. The ICSs we were working with understood the importance of this work, and they did things like send out text messages to patients, send people to clinics to fill these out with patients in person. We had GP practices texting patients, all kinds of different things. We got 520 people to fill out this survey, which makes it one of the largest COPD discrete choice experiments in the world. Here's some demographic stats. The important one, which we were very disappointed about, is that 98% of people who responded to our survey were white. So this is not a representative survey of the population. However, when we showed this to the ICSs we were working with, they said, well, actually, those are the people who are coming to our clinics. That's sort of representative of who is accessing care. So that led to lots of interesting discussions about why that is. So this is probably not the most representative sample, but was useful in other ways. What did we find? This isn't that groundbreaking, these findings, but it gets more interesting, I promise. So the attributes that are most important for people: outcomes, treatment delivery, and the type of staff delivering treatment. When we then look at within the levels, there is actually some interesting, potentially hard to explain findings. So the first one is treatment outcomes. We found that people had a higher preference, so higher perceived utility for little or some relief over complete relief, which doesn't make sense. People prefer not to get complete relief from their treatment. So when we showed this to the ICSs, we did it in sort of big workshops. We had nurses, patients, public health people, all of that. A couple of potential interpretations that we found for this are: one, COPD, chronic obstructive pulmonary disease, is a chronic condition. People don't expect complete relief from their treatment. That's not what they've got, a condition they know they're going to die with. So perhaps it was just they weren't expecting it. Another one is things that give people complete relief. The sort of interventions will require large trade-offs, big lifestyle changes. You have to do lots of intensive exercise, quit smoking, or you have to have an invasive surgical procedure. So actually, perhaps, and we didn't test for this in the survey, but perhaps people didn't want complete relief because they didn't want to do that. Actually, what they wanted was just to be able to walk up the stairs without getting breathless. That's all they wanted from their treatment. Treatment delivery, strong preference for in-person individual appointment, not groundbreaking. What was more interesting was there was indifference between online individual appointments and in-person group appointments. So this is really helpful for planning COPD services because services like pulmonary rehabilitation, these are the options that people are offered. And actually, in-person group appointments require rooms, staff, lots of resource. Online is much easier. So if there's indifference between those, perhaps online is a lot easier for people to do. Travel time, people don't want to travel that far. And people wouldn't mind actually paying a bit of money. Again, probably expect to pay for a bus ticket to get to the hospital. Waiting times, in fact, actually, people didn't mind waiting up to 6 months to see their healthcare professional, which I know there was a talk about RTT waiting times earlier today. That does suggest maybe that's not the best metric. And also people would like to see healthcare professional. That was the type of professional that they most wanted to see. So again, these perhaps aren't groundbreaking in themselves, but they led to some really good discussion. So first thing that's clear here is perhaps what people don't want is someone, a physio, occupational therapist, all of these people going to their house every day and asking them a load of questions, giving them new loads of drugs. Actually, probably what they want is an impactful session with a healthcare professional less frequently. This also, the healthcare professional thing was a point of great discussion, because if for COPD, there's lots of sort of group therapy sessions offered for people, run by Asthma and Lung UK and others, that have been shown. There's studies which show they are beneficial for people's health, but they're not always well attended. So a lot of people are thinking, well, actually, why don't we get a GP to go to those group sessions? More people will go to the group sessions. The GP gets to see 20 people in one go. It's a win-win. So yeah, some really useful findings from this survey. I think there was a few when we were presenting this finding. So this is what the sort of raw output looks like. One of the learnings for us is that this takes a bit of, from going from the series of options and clicking on each one, getting these scores, there's a bit of a jump in understanding. So communicating this to stakeholders can be quite difficult, and perhaps meant that some people didn't trust it as much as they could. Whereas if you ask people, rate out of 10 how much you would like this thing, that is very easy to understand. 9 out of 10, everyone knows what that means when it's out the other end, kind of thing. But there we go. But really, I think what I'm really passionate about discrete choice experiments is this. So once you've got all of that preference data in a database, you can start building theoretical scenarios of these different options. And you can then look at, of everyone that we spoke to, how many of them would prefer option 1 over option 2, or option 2 over all of these options. So you can see here in these, these are just completely made up scenarios, but you can see what this shows is, of everyone we asked, 45% of people would prefer option 2. Now, if you were planning a service or something like that, you could set these attributes to what important things are for your service. Then perhaps for pulmonary rehabilitation, this is essentially you get someone to go to a gym, you give them some training and learning on their condition, and do some exercises, send them home. You could, if you were thinking about a service, you could vary these and say, okay, one way of us doing it is an in-person group appointment, might be some out-of-pocket expenses, won't be seen by a healthcare professional, so perhaps we can get lots of these courses done. Or perhaps we could also do it in a hospital. People would be seen individually by a healthcare professional, but they'd have to wait a bit longer. You can then see, of your population, which of those options people would prefer. You can have services which are directly informed by what people want, and not just one person in the boardroom, but large groups of people. So that's why I'm really passionate about this methodology. I think it can really be helpful for the NHS services. So I think that's it. Thank you for listening.